Okay, so we started out practicing math for review and I hadn't pushed record yet. So now we're recording. So we practiced the newborn eats and how you figure out that formula. And we converted our mLs to ounces. And then we figured out how many calories, based on the calories per ounce, how many calories per feed, then how many feeds per day. And then we solved that. Okay. All right, so now we're doing okay. Now we're looking at Pitocin. And so the Pitocin problem has 2 millunits per minute, and we have 30 units in a 500 ml bag. And so we're looking at what our infusion rate would be. Okay, so milliunits per minute. If I want to make milliunits into units, how could I do that? Anybody know?
Multiply by 1,000.
Multiply.
By 1,000.
Okay, you want to multiply milliunits by 1,000, and then we would have 2,000 units. Let's try that if this was milligrams. If I had 2 milligrams times 1,000, then I would have 2,000 grams. Is that right?
Yes.
We actually needed to go the other direction. Milliunits are smaller. And so what we actually are going to need to do here is divide. So we need to divide by 1,000. In order to convert this to units, if we divide by 1,000, then we find that 0.002 is the number of units. Okay, converting milliunits to units. Now we need to consider time because it is dosing it in milliunits per minute and our infusion rate is in milliliters per hour. So now let's take our units dose and times it by 60 minutes in an hour. Okay. So then what do we have?
$0.112.
Okay, good. 0.12 units per hour. So guys, now that we have made those conversions, the rest of this should be easy to solve because now we know what our dose is and it matches what we have on hand. And it matches that we want to infuse in milliliters per hour. So what do you want to do next?
Times 500 milliliters.
Say that again.
Times 500 milliliters.
Okay. And then what do we get?
0.03.
What is it? 3.03?
0.03.
I mean, did you say 0.03? This isn't the way that I solve it, so I don't know what this part is. Hold on. Times, this will still work, I think, but. Well, if we times 0.12, which is our dose, times 500 mLs, I got 60. Then we need one more thing. We have to do one more thing here. So we took our dose, we times it by the number of milliliters in our bag, but we still have to take into consideration the 30 units is what's in the bag, and we're going to give 1.12 units per hour. So we could do this and then divide. The way I would actually set this up is I try to get problems to the point that I can use want over have times volume. And I would set it up like that. So now what I want is 0.12, right? Over what I have is 30 units in the bag times the volume, which is 500 mLs. So if you do 0.12 divided by 30, and if we did what you just said and we multiplied it by 500 first, we still needed to divide it by 30, and we would have still got the same answer. But what's that?
The answer is 2.
And then the answer is 2. And it's 2 what?
Yes. 2 milliliters per hour.
Yeah, 2 milliliters per hour. Okay. Makes sense. I think Brandy, you were the one that wanted to do that one. Is that helpful?
Yes.
Okay. Any other math we want to look at before we play our game? Do you want to do heparin?
Yes.
Okay, let me find a heparin one. So I'm still using that same document that the multi-step math, because I think I have a heparin one in there too, and I'm just going to grab that. Here we go. So here's a heparin question. All right. So we have 12 units per kilo per hour of heparin infusion. The patient weighs 200 pounds, and we're supplied with 30,000 units in a 500 ml bag. What's the ml per hour infusion rate? So what should we do first?
Calculate the patient's weight.
Convert pounds to kilograms.
Okay, let's do the weight. So the patient weighs 200 pounds. I don't want this to have a highlight behind it. Let's see here. Oops. No, it's gonna, that's all right. 200 pounds is how much the patient weighs. How am I going to figure out the kilos?
By 2.2.
Divided by 2.2. Okay. Whoops. Not 202. 2.2. And what do we get?
90.9.
So on my calculator, this is one of those times, guys, that you know how I said to wait to the end to round? This is one of those times we're going to need to wait to the end to round. So keep it on your calculator. So on the calculator, I did 200 divided by 2.2. And so I get 90.9090, and it keeps going. Okay. Just leave it as that number on your calculator. Don't do anything else with it. Don't round it. Okay. So now we're going to keep the number big, and we're going to, what are we going to do next?
Multiply by 12.
Multiply by 12. So we're going to do 12 times, and then the 90 point, and all the 90s, right? And so just leave that number on your calculator as that long run-on number, and then just hit times 12. And then we get 1090 point, and then all the 90s again. Right?
Yeah.
Okay. From here, I will come back now. I know my dose, and I will come back to desired over have, or want over have, times volume. And so what we want is this one, 1090.909090 number. So keeping it big on your phone or calculator, sorry, it's not, mine's on my phone, is what we want. Divided by what we have. What do we have?
So we have 30,000 units.
30,000 units. So on your calculator, keeping that number big, oh, I don't know what I just did to mine. Hold on. I have to clear it real quick. Hold on. 12 times 200 divided by 2.2 equals times 12 equals, okay. Now we're going to just leave that number long on your device and then do the next step, which is divide by 30,000.
Mm-hmm.
Okay. And then we got to multiply by our volume.
Volume 500.
And then what do you end up with? 18.18. So then we have to go back and look, and it doesn't say where to round. And so, I think, guys, 99% of the time you should be told where to round to. All right. So I don't want you usually to assume. For this patient, this probably is going to round to the nearest whole number, because this is an adult on heparin. But what if this was a micro preemie baby? It might round to the hundreds. We don't know. But let's say it says to round to the nearest, let's say 100th. How would I round to the nearest 100th?
That'll be 18.18.
So this is the 10th space. This is the 100th space.
Mm-hmm.
And so we're going to round to this number. So we're going to look at the number after it. And if this number is 5 or higher, we're going to round up. If the number is 4 or lower, we're going to leave this number the same. And since this is a 1, then the answer would be 18.18. Because we wouldn't round up, we would leave it the same. Okay. So most problems you can, as long as you can get them to the point where you have to figure out what your dose is. So we need to figure out desired, and that's what we had to do up here with what the newborn's eating. We had to do our conversions to figure out what our dose was, and that's what we had to do here with our oxytocin. We had to get to a dose where everything matched, right? And that's what we did here with the heparin as well, as we had to get to a dose. And if you do this, and so here, let me show you what happens if we rounded early. So if the patient's 200 divided by 2.2, oh, come on. And we got 90.909090, and so we just said 90.9, let's say, right? And then we finish solving it that way. Then 12 times 90.9 is 1090.8. And then that is going to be our dose, right? Divided by 30,000 times 500. Hold on. Actually, this one might actually be fine. I wanted to show you how you could be off a little, but this one might actually be okay. And then it doesn't enunciate what I wanted you to see. Let me see. 2.2 times 12 divided by 30,000 times 500. All right, for this problem, it would have been okay. But it isn't always. It really kind of depends on what's trailing back here and how much of a number difference it is. and it can make your number be 1 or 2 or 3 off on your solution. And in like a micropreemie, that's a huge difference for medication.
Mhm.
Okay. So for this particular problem, it wasn't going to make a difference. So, but for some of them, it really makes a huge difference. So just let that number be long on your calculator and keep going to your next steps. And try to work these problems down to the point where you can do desired over half times volume. So do all of your conversions and make everything match. And then do desired over half times volume and you should be good. And then watch your conversions and your rounding. Any other math we want to look at? You guys still ready to play my game?
Yes.
Okay.
Thank you. Hi. I will get out of here. No, it's okay. I'm gonna go to the bathroom. He's fine. No, I'm just taking some of the off me.
Maybe we'll play my game. So when I started my computer, it logged me out. There we go. I was getting nervous for a second. ECM2 review. Okay. So for this game, you can use the QR code, or you can click this link that I just put in the chat. If you click the link, it's going to take you off of my screen, but the question will still show in the game. Are some of you getting bumped out? I see some coming in and then going back out. I'm gonna have you guys hold on for 1 second, okay? Because I'm gonna pause this. Here we go. All right, here we go. So a 39-week client reports that her water broke 12 hours ago. Her temperature is 100.8, heart rate's 110, fetal heart rate's 175. What's the primary concern for her? Okay, good. So we're worried about chorioamnionitis. So chorioamnionitis is that infection, right, that can happen in the uterine cavity. What kind of signs and symptoms might we see? Like what in the description of her condition clued you into thinking that this might be what's going on?
Temperature,
Temperature. Okay, so she has a fever. What else?
The
the
baby's
fetal heart rate,
Good. Yep. So baby and mom both can be tacky when mom has a fever and when mom has infection. Good. So fetal heart rate. Also, mom's heart rate was elevated. What else with chorioamnionitis might we see besides these?
12 hours of water will grow.
Okay, yeah, it's been 12 hours.
will introduce infection.
Okay. Any other symptom that isn't listed here that we might see with choreo?
nausea,
Discolored, foul smelling,
Yeah.
amniotic fluid.
Yeah, good.
Yes.
So foul smelling fluid, it could have a discoloration, like be purulent. Yep. Maybe she could also have some tenderness in her uterus, just because if the infection's there, right? Good. Yeah. A client has an incompetent cervix at 20 weeks. Which intervention will be ordered to prevent preterm birth? Excuse me. Okay, good. Let's talk about this for a second. What does it mean if she has an incompetent cervix?
She could have
it's dilating,
a miscarriage, bleeding.
Yeah, okay, good. At 20 weeks, that baby's not going to survive, right? For those of you that answer tocolytics are medicines that do what?
Move the muscle.
induced labor,
It's a uterotonic.
Uterotonics squeeze, tocolytics relax. So I understand the idea of this. The idea of using a tocolytic for this to try to make the uterus relax is not a bad idea, but it doesn't mean that her uterus was contracting and that was what was causing her cervix to thin or dilate. It just means an incompetent cervix or cervical insufficiency is just a cervix that's not staying closed. And so it's not necessarily contractions that are causing it. It's just not doing its job. And so at 20 weeks, this baby's not going to survive. We need to try to keep the cervix closed, and that's where we can do a cerclage. Does anybody know what a cerclage is?
They stitch it shut.
Yeah, they stitch it.
Stitch it shut.
They stitch it shut. So it's like it goes kind of around like purse strings and pulls it, keeps it closed. Okay. And so for this client, we could put in a cerclage, and then they'll usually take it out around 34 weeks. And after that, then if her cervix dilates at 34 weeks, that's considered late preterm, and babies usually at that point do fine.
Mhm.
Okay. Um, okay. The nurse is caring for a client who has a placenta previa. Which of the following findings should the nurse expect? Oh shoot, I looked away. Okay, hold on. We'll talk about previa in a second after the next question. The nurse is documenting assessment findings on a client 14 days postpartum, which indicates a normal involution process. Okay. So for this, we're 14 days postpartum, and it wants to know normal involution. What happens with involution?
That's where the fundus is done return, like it's returning back down.
That's
That's
the
where-
uterus return back to its normal state.
Good. And so how much per day for normal involution, how much per day should the uterus be going down?
1 centimeter.
A centimeter
One
a
to
day. Okay. Yeah, 1 to 2. But so if we say a centimeter per day, or 1 to 2, then we should be by 14 days. If you're thinking about a centimeter per day, and where do we start at? After the baby's born, where do we find it? Right at delivery.
The umbilicus.
So if it starts at the umbilicus and we're going down 1 to 2, by 14 days, we shouldn't be able to palpate it anymore.
Right.
Now, previous question, because I didn't pause it in time. There was a previous question about placenta previa. For placenta previa, what are some things that give us an indication that our patient has a placenta previa?
Painless bleeding,
Yeah.
Painless, yep.
Right. And
What's-
low lying,
Right. So that's kind of the problem, right? Is that it's the placenta is down low, kind of overlapping the cervix. Okay.
bright red bleeding.
Bright red. Good. During a vaginal delivery, the fetal head is delivered, but the shoulders do not follow. What is the first maneuver the nurse should assist with? Okay. So first thing to do is McRoberts. Okay. Because think about least invasive to most invasive, right? McRoberts maneuver, how do we do it?
pushing down on the part of the abdomen to relieve the shoulder from underneath that ledge, that
Not
the
quite.
ridge or whatever.
Yep, that's
sorry.
when that's not quite McRoberts. That's suprapubic pressure, and that's going to be the next good thing to do.
It
The
is
first,
the knees on chest.
so first is
Knees
McRoberts.
to chest.
So,
Knees to chest.
and the way that with McRoberts, we're going to send her knees towards her ears, right? The reason that I don't want to say knee to chest because, and we are kind of putting her knees on her chest, but the reason I try to watch the way I explain that is because that we have a position called knee chest, which is a different position that we use for a cord prolapse, where the knees are on the bed, the chest is on the bed, and the butt's up in the air. So McRoberts is not that position, right? McRoberts, she's still on her back. It's true that we kind of are putting her knees on her chest, but I just don't want you guys to mix those two up. So if you put her thighs on her belly, that would be, okay, so it's still the same idea. We want her legs to go back. So if I'm in a delivery, and usually as a nurse, you're like helping hold a leg, or you're right there, and the head comes out, and oftentimes we see what's called a turtle sign, where like there's momentum and then comes back. So you see the provider with their hands on the head and they're guiding it, and then it kind of hits the bone, right? The first thing I'll do is lower the head of the bed and start pushing, because if you're holding their legs, if you push up on their foot, then that's changing the position of the pelvis to try to give the baby room to come underneath the pubic bone. That's McRoberts maneuver. That's the good first maneuver to try. If I do not immediately see this shoulder release with McRoberts, I'm calling for help. And I'm preparing to do suprapubic pressure, which was the one that Nikayla was talking about. And so we'll even bring like a stool to the bedside if we know that we have we're expecting a big baby or something that could increase her risk of shoulder dystocia, so that I can get up onto a higher plane to do that pressure. Okay, but for McRoberts, this one we're just going to change the diameter of her pelvis by flexing her knees back. Does that make sense?
You said when you call for help.
And call for help. That's what, yeah, as soon as if I see turtle sign and I start McRoberts and I don't immediately see that shoulder release, I'm pulling my light. Because we're going to need extra hands. And I've had some shoulder dystocias that have gone for several minutes, to where we're bringing in a lot of people. And not only because at that point, not only because we need help getting the baby out, but we're also going to need help to potentially resuscitate that baby after. Because the more time that the head is out and the body is in the vagina, the more time that there's compression happening on that cord. And so we're not getting oxygenated blood to our baby. So it's an emergency for sure. A delivered client has a temp of 101.4. The uterus is tender, unusually large, and not descending. What should the nurse assess next? All right. So those of you that selected the lochia, what are you looking for?
Bleeding.
Okay. Do you think that this patient might be bleeding?
I'm looking at the color of the blood because it should be telling me something. Am I correct? If it's like if she's bleeding, soaking through heavily, that means she's hemorrhaging, correct?
That's true.
It should not go back to located.
It shouldn't go back to rubra. Here's the thing with this question. It doesn't tell us how long. No, I think you knew what you meant. I knew what you meant. It doesn't tell us how long ago she delivered. Okay. So I don't know how far after delivery we are, but she has something happening because it says unusually large for her uterus. She has subinvolution. Her uterus is not returning to its pre-pregnant state because it says it's unusually large and not descending. Also, she has a fever and her uterus is tender.
Isn't that
So,
a sign of infection?
yeah, what infection might she have?
For real?
Well, so chorioamnionitis is going to be the infection while she's still pregnant. But the chorion and the amnion are not, yes. So the chorion and the amnion are out now. So the infection could be what Brandy said, endometritis, which is an infection of what?
Endometrium.
Which is the lining of the uterus.
Inside.
So she's got signs of infection, right? She has a temperature and a tender uterus. She also has signs of subinvolution, where her uterus isn't returning to its pre-pregnant state. Okay, it's unusually large and not descending. I'm going to tell you guys that infection is one of the main causes of subinvolution. And so that really fits. But subinvolution can cause late postpartum hemorrhage. So lochia, looking at her lochia, there's a few things I would look for. Number one, what you guys were saying about bleeding, right? Is it rubra when it shouldn't be? Is there a lot of it, like volume? And then we can also look to see if it's got like an odor, if it's purulent, things like that, which would go with the infection part. Okay. I thought somebody else started to say something. I wanted to give you guys a minute to see if you had something else to say about this.
No, I was just gonna say, is that the first, like when they mean like the atani, the atony, so they have they're like basically her it's not firm, so it's kind of boggy still, so she can be at the risk for hemorrhage still, but you still want to assess her by the amount of blood, the color, and the odor.
Yes, except there's a little bit of a difference between subinvolution and uterine atony. And basically, uterine atony is going to be our number one cause of hemorrhage in the first 24 hours after delivery. And correct that the uterus is not contracting, it's boggy, we can have lots of bleeding happening there. After that first 24 hours, subinvolution is going to be where the uterus isn't returning back. So it still really isn't contracting well. Okay. But it's not necessarily, it's a little bit different between early postpartum hemorrhage is atony, late postpartum hemorrhage is subinvolution. And the causes are a little bit different because with early hemorrhage, here, hold on. With early hemorrhage, I don't know why I did that because none of you have your camera on. I just like to feel like I'm looking at you when I'm talking to you instead of just looking at the screen. Early hemorrhage is going to be the absence of tone or atony, right? Can be caused by retained placental fragments keeping the uterus from contracting down. Can be caused by like a coagulation issue. That's not really what's keeping her uterus from contracting, but it's keeping her bleeding. But the absence of tone or the uterus not squeezing well is going to be what really makes us hemorrhage in the first 24 hours. But late hemorrhage is usually because it still can be retained placental fragments that's keeping the uterus from returning to its pre-pregnant state, but also this infection, like endometritis, that can also keep the uterus from returning to its pre-pregnant state. Still, we're seeing bleeding here. We're seeing a uterus that's not returning like it should, because we just talked about how it should be going down about a centimeter per day. And so that's not happening. And we can see that for several weeks, up to 6 weeks after birth. So they're a little bit different, but similar enough. Does that make sense?
You want to explain it in?
Yes, because it explains the difference between subinvolution and uterine atony. Antony. How do you say it? Uterine.
It's atony, but that's okay. As long
Okay.
as you,
Yeah,
as long as you
atony.
recognize it when you see it, that's all right.
Yeah, it's not too clear, the difference between early and late.
Early happens in the first 24 hours. Number one cause is uterine atony. Other causes of hemorrhage in the first 24 hours or early hemorrhage is unrepaired lacerations, hematomas, Let me think.
We're talking about hemorrhage or we're talking about the uterus not descending?
So we kind of are talking about both because we were talking about this question where she had signs of this. I've already forgotten where we were at. She had signs of infection
Mhm.
and her uterus was still enlarged. And so if we have endometritis, so she had a fever and she had, let me see what else she had, and a tender uterus. Okay. For her, I do want to look at her lochia, number one, because she could have purulent discharge. She could have foul-smelling odor. These are all things we could see with her infection. But it also said that her uterus was unusually large and not descending, and that is subinvolution. That's the uterus not returning to its pre-pregnant state. That's something that happens over time, and that can cause a late hemorrhage where she can be bleeding more. So looking at her lochia also lets us know how much blood loss she's having. Because she should only have rubra for the first few days, and then it should be switching to serosa. And so if she's still having bleeding, well, something's going on with that. That all of that is your late hemorrhage. Your
So late,
early hemorrhage is what
late
happens in
late hemorrhage, we're gonna see the rubor comes back.
the rubra could go back from, you could see like serosa go back to rubra with late hemorrhage. Early hemorrhage is the first 24 hours, and that one is our T's, tone, tissue, trauma, thrombin. So uterine tone is the number one cause of early hemorrhage. Okay, that's where we need to make the uterus contract, massage the fundus, give the medications, manage the bladder, all of that. Okay, but we're not doing that for this patient over here that's having late hemorrhage with subinvolution. Now it's not because her bladder's full. It's not because of those things, right? She's having this prolonged problem. In the early hemorrhage, we're fixing an acute problem. So we're managing the bladder, we're giving meds, we're massaging the fundus if we have atony. If we have, so that's tone. If it's tissue, then it could be fragments of the placenta that are inside that need to come out. And that one can happen for both early and late.
And late.
Okay. For our early hemorrhage, the tone, we did tone and tissue. Trauma is going to be the unrepaired lacerations that are bleeding, where you have a firm fundus, but you're still seeing blood coming out. It could also be a hematoma. So it's got damage to the tissue. So that's
So
trauma.
we have hematoma in the early hemorrhage,
Early hemorrhage could have the hematoma.
but not the late.
Mm-mm. Nope. Late hemorrhage is subinvolution.
Mhm.
Subinvolution is usually caused by infection inside or retained placental fragments.
Mhm.
Early hemorrhage, number one cause of early hemorrhage is atony.
Mhm.
We should like draw a tree thing and like put it like and then like branch them out. All right, there's more questions about that. So in the game. So let's see if we can get more clarity. A nurse assesses dark red bloody discharge that with scant or moderate flow. The nurse educates that all right, so if it's dark red and bloody, that's rubra. Okay, correct that it should only last for a few days. Also true that if she stands up, she might get a gush, or when she's breastfeeding, she might get a gush. If she's sitting or laying down and it like the little bit that's coming out kind of pools in her vagina, then when she stands up, she can get a little gush there. Okay. Breastfeeding can increase it because that during breastfeeding, what hormone is her body releasing with breastfeeding that helps the milk let down?
Oxytocin
Oxytocin. And so what is that also going to do for her uterus?
is going to contract it.
It's gonna contract the uterus.
Yeah, which is great, right? That's the body's natural way to help the uterus with involution, but it also can cause cramping for her. Sometimes we will medicate our patients and give them ibuprofen before they feed if or give them heat packs for their belly and stuff because sometimes it's uncomfortable. But it also can cause her to have a little bit more lochia during that time because the uterus is squeezing. Okay. A client's diagnosed with preeclampsia. What finding could indicate the client may be developing HELLP syndrome? All right, let's talk about this one. So HELLP syndrome, guys, is a variation of preeclampsia. You can be preeclamptic and not have HELLP syndrome. But if you have HELLP syndrome, you are preeclamptic. Does that make sense? Yes, no?
Yes,
Yes.
but I'm trying to like the quadrant, the gastric like pain in the upper right quadrant plane, like it's kind of throwing me off because I know that a lot of times when we speak about preeclampsia, that they do want to make sure that the monitoring is prioritized to excessive headaches and blurred vision.
Well, not specific to HELLP syndrome, though. So,
So that's the crisis, maybe.
well, HELLP syndrome is going to have more liver involvement. Okay, if you look in your book, there's a few places where there's like a table or a figure or something that shows like some of the lab values are a little bit different here. But what we see with HELLP syndrome is much more liver involvement. So right upper quadrant pain is right upper quadrants where the liver lives. So if we're
The
having a lot of
swollen,
right
right?
upper quadrant pain, not necessarily an increase in swelling either. We're really what happens with HELLP syndrome. HELLP syndrome stands for hemolysis, elevated liver enzymes, and low platelets. And it is true that we can have elevated liver enzymes and low platelets with preeclampsia, but with HELLP syndrome, they're much more pronounced. We have a lot more liver involvement, so we have more pain in the right upper quadrant or epigastric. And then the platelets can be garbage. So with preeclampsia in general, thrombocytopenia is less than 100,000. With HELLP syndrome, it's less than. I don't know I was gonna see if I can look in the book and see what the amount was. Maybe I can just grab that table. Hold on. But so the low platelets are significantly low. HELLP syndrome is a more severe and a lot more concerning. I have seen patients that are very preterm that are emergently delivered because because of HELLP syndrome. To the point, let's see, normal non-pregnant HELLP syndrome. I want to find a little chart here. Here we go. So the platelets can be so low, like so dangerously low. Like I've seen them do emergency C-sections on patients that are like 27 weeks and stuff like that, where we would normally, with preeclampsia, maybe still try to keep them pregnant a little bit longer. But so like this is just a table in the book. So this is comparing normal labs for a normal non-pregnant woman, a preeclamptic woman, and HELLP syndrome. And well, it doesn't really specify. It just says less than 100,000 for both, but the platelets drop very low. So like I had a patient that her platelets were 50,000. And her baby was 27 weeks. That's why 27 weeks stuck in my mind. And we sent her by helicopter to a higher level of care where they could take care of a baby that young, because my hospital only goes down to 30 weeks. And by the time she got from our facility to that facility, her platelets had dropped from 50,000 down to like 38. And they did emergency C-section. Her platelets were just dropping so fast. And so this, with HELLP syndrome, this is a much more severe form of preeclampsia that requires immediate interventions. So for this, we're really worried about thrombocytopenia. We're really worried about the epigastric pain and the right upper quadrant pain. And we're still going to see signs of preeclampsia. So we're still monitoring the blood pressure, and we're still worried about her having a seizure. She still needs to be on MAG, stuff like that. So HELLP syndrome is just more severe. Does that make sense?
Yes.
Thankfully not as common, because it's a very scary condition. And when their platelets are dropping like that, they're at a huge risk of bleeding. I've had patients with HELLP syndrome that we are inducing labor for, and they couldn't get an epidural because their platelets were too low. And so that's really hard too, that sorry, no epidural for you. Okay. So for this question, what finding could indicate she may be developing HELLP syndrome? This is going to be that involvement of the right upper quadrant pain, the epigastric pain.
Lab
Seeing blur
values.
and the lab
Oh, I'm
values.
sorry.
No, you're right. But just on the question itself of the choices, the epigastric pain, the right upper quadrant pain was the best choice. The blurry vision and the flashes of light, those can be things we see with preeclampsia in general. So that's not an indication that we're developing HELLP. Okay. The nurse is caring for a client with an ectopic pregnancy. Which findings does the nurse expect? Yeah. Okay. With an ectopic pregnancy, all of these things could be happening. She's going to have a positive pregnancy test, because that when the embryo attaches to the fallopian tube or wherever, the body's still going to start releasing HCG. Like, that's how that works. As soon as it attaches. So she's still going to have a positive pregnancy test. Pelvic pain and vaginal bleeding are signs. And that's usually what brings her in. If she's having pelvic pain and vaginal bleeding, and they find that she does indeed have an ectopic pregnancy, can the baby continue to grow where it's at? Where is the pregnancy if it's ectopic?
Fallopian tubes.
Outside of the uterus.
Or the abdominal.
Yeah, so it can't stay there. So if the fallopian tube is not damaged, they can give her a medicine called methotrexate, and it's going to stop the growth of the embryo. And it'll resolve the ectopic. If it has grown to the point that has ruptured the fallopian tube, then they have to do surgery. And she can lose a lot of blood in her belly. And so this could be a hemorrhage risk as well. Which statement should alert the nurse to the worsening of gestational hypertension? So this one is going to be the vision. Okay. So my vision for the past 2 days has been really blurry. that could be a sign that, so gestational hypertension, what's happening with gestational hypertension?
You developed it during
Preeclampsia.
pregnancy?
So it's not preeclampsia yet. It's hypertension that's related to the pregnancy. She wasn't hypertensive before she got pregnant. This developed after 20 weeks that she has high blood pressure greater than 140 or greater than 90. And so she has gestational hypertension. A patient that has gestational hypertension is at increased risk of developing preeclampsia. And so when this question is asking what could be an indication of worsening, would be if it's turning into preeclampsia. And so then we got to think about our preeclampsia symptoms, right? So visual changes or blurry vision or the floaters and stuff like that is one sign. What other signs might we have of preeclampsia that she might develop?
Swelling of the face
Increased urine
Protein
output.
in the urine and edema.
and protein.
Protein in the urine, a sudden onset of edema,
Mm-hmm.
especially like in the hands and face. If she's been, if she has some swelling in her feet, she's been on her feet all day, I'm not worried about that. Some of that is normal, but if we have a sudden onset of edema, especially in the hands and face, that can be concerning. Also the headache. They can get this, it's often in the front, like this frontal headache, and they've been taking Tylenol and they've been hydrating and all these things, and it's not getting better. That could be a sign. So visual changes, headache. They also could have some epigastric pain. So we can see some epigastric pain and right upper quadrant pain with preeclampsia. It's just not as severe as what we were talking about with HELLP syndrome. Okay, with that increased liver involvement. So any of those statements from this patient who already has gestational hypertension are like big red flags that she could be developing preeclampsia. Which of the following amounts of blood loss following birth mark the criterion for describing a postpartum hemorrhage? Good, more than 500. So more than 500 for a vaginal birth, right? What do we say our criteria is for a C-section?
1,000.
Yep. A nurse is reviewing the electronic fetal monitoring tracing of a client with ruptured membranes. Which findings may indicate a cord prolapse? Okay, let's talk about this. Okay, what's happening with a cord prolapse?
That mean that
The cord is hanging out of the uterus.
Oh, yeah, verbal
The cord is hanging out of the body.
Okay, the cord has come down ahead of the presenting part. Honestly, it may not be all the way where you could see it. Sometimes we feel it with our fingers in her vagina, but it is in front of the baby. So it's in the vagina or it's outside of her body. Okay, is this bad?
Yes, it can risk infection. It's high risk for infection, correct? And fetal heart rate complications.
Yeah. My bigger concern truly for this is going to be the baby. Because let's think about it. If the cord is down in front of the presenting part, so we're going to say the head, because truly if we're at this point, the baby hopefully is head down. But I've seen this happen with a cord prolapse with a baby that's breech. It's actually it's a lot more common if your baby is breech or transverse, because then you don't have the presenting part that's well seated in the pelvis. When the water breaks, this is the primary time to see the cord prolapse, because the water, as it comes out, it can just carry that cord right with it. If it comes down in front of the presenting part, if it's in front of the head is going to come down, especially when she contracts, and it's going to put pressure on and completely occlude the cord. Okay, so the biggest concern is going to be oxygenation, right? If the head is putting pressure on the cord and occluding it, all of that good oxygenated blood coming in from the placenta, not doing it. It's not coming. Okay, so it's kind of like holding your
So is
breath.
that why you would want to, so is that why you would want to like get a sterile, if it's out of the vagina, you want to get a sterile towel, right? To cover the cord and then put your hand in to relieve the pressure off of the cord from the baby, right? Like if the
We want
baby's
to get the
head, if it's
pressure.
prolapsed and it's out, you want to get the pressure off. So you would want to stick your hand in to kind of like relieve the pressure off of the cord, correct?
Yep, we got to get the baby off of, like, take as much pressure off the cord as possible. And so putting a sterile glove on and with your fingers in the vagina pushing up on the part that is coming down. So I'm going to say the head, pushing up on the head to try to minimize the pressure on the cord. Okay, that everything we think about with a cord prolapse is going to be towards oxygenating the baby. True that I can wrap the cord in sterile saline soaked gauze. And if the cord prolapsed and she's outside of the hospital, I definitely think that's a good idea, because if the cord gets dry, and it'll start having like vasospasms. We don't want to put the cord back in, because that can also make it vasospasm, and then it's constricting itself even more. And so those are things to consider, but really, like in the hospital setting, we are going straight to the OR. This baby has to come out, and it's going to come out by a C-section because the cord's already in the vagina. Okay, so we can't really pull the baby, have her push, and there's going to be so much pressure on the cord. So we're going straight to the OR, and we need to relieve as much pressure on the cord as possible until we can get the baby out with the C-section. So pushing up on the presenting part can help, and also position changes. So this is where, when we were talking about using McRoberts, and I said I didn't want you guys to confuse the positions, this is where the knee chest position can help, where she gets on her knees and then hunkers over so her chest is on the bed, so that her bottom's up in the air, and it lets gravity help rock the baby back off the cord. We could also use a Trendelenburg position for this, where we lower the head of the bed. I've been doing some reading about, if we do Trendelenburg when she's just on her back, that can actually cause vena cava syndrome, right? Because now we're rocking the baby onto vena cava. So if we did that, we would also have her in a sideline position if we use Trendelenburg. But the idea is going to be position change to help get the pressure off the cord, and fingers on pushing up on the head to get the pressure off the cord. And we have to do emergency delivery. Other considerations, we could wrap the cord, we could give her oxygen. These things aren't going to relieve the pressure on the cord. So I want you guys to really be thinking about the priority as far as oxygenation for our baby, and keeping that open as much as possible. As far as what we can see when this happens, here we've got this fetal heart rate that just tanked, and we're having severe variable decelerations. Variable decelerations are caused by what?
Prolapse cord.
Well, yes, is a prolapsed cord, but but when we do veal
Insufficient.
chop,
And inadequate perfusion to the baby.
so remember veal chop, let me see if I got this other thing I can
I thought it
show.
would be like cord compression then.
Yes. And so here's the thing, is that we can see variable decelerations with any type of core compression, right? But if we are having variable decelerations, we need to be considering the fact that it could be like, where's the pressure on the cord? So it could be, remember, like typically our big thing is like if we're having variable decelerations, what's the good first thing to do? Just in general, outside of core compression.
Reposition the
Reposition
mom.
the mom.
Reposition the mom. Okay, so variable decelerations can be caused by cord compression in general. So if I'm seeing if I'm seeing variable decelerations, we should reposition the mom and see if we can relieve pressure on the cord. And so if we are having variable decelerations, we reposition the mom. I was going to pull this up for us real quick. Remember veal chop? Variable decelerations have that abrupt onset, and they're caused by cord compression. So moving the mom is a good first thing to do. So in real life, if I suddenly see variable decelerations on my monitor, I'm going to go in and adjust the mom. Okay. If this isn't fixing my decels, I need to kind of think, well, what's putting pressure on the cord? Sometimes the baby's holding their cord and squeezing it. Sometimes the cord is wrapped around the baby a bunch, and no matter what position I put the baby in, we're getting pressure on the cord. Sometimes it's a cord prolapse. Okay, and you don't know. You just are seeing variable decelerations. So the things that can clue you in are going to be if her water just broke. That's a huge time that we see a cord prolapse. So if our tracing's been great and now the water broke and now I'm having big decels, that could be a sign of cord compression because of a cord prolapse as opposed to just other things that compress the cord. And that actually happened 2 weeks ago. Patient totally fine tracing, everything's good. All of a sudden, water breaks, decels. The nurse goes in, repositions, not better. So then they check her, and the cord's in the vagina. Okay. So variable decelerations don't have to mean cord prolapse, but they can mean cord prolapse because of the cord compression that happens with the prolapse. Does that make sense? So if you're seeing variable decelerations, then that's something to keep in your mind. It could be a cord prolapse. If it's a cord prolapse, we want to hold the presenting part off the cord. We want to put her in position like knee chest. We want to go to the OR and have a C-section. Okay, and very fast because we're having decreased oxygenation to our baby. And so the other things, wrapping the cord in the saline-soaked towel, giving her oxygen, those things are all fine ideas, but those aren't fixing our problem. And I want you guys to think about the baby's getting all of its oxygen through that umbilical cord. So we're essentially asking this baby to hold his breath. Okay, how long can you hold your breath? That's how much time you have. Okay, make sense? All right, let's go back to this. So for this one, the water broke, and then we suddenly had a fetal heart rate that dropped to 80 with severe variable decelerations. That's a huge red flag that's so much pressure on the cord. That's a cord prolapse. After precipitous delivery, the patient has a continuous bright red blood trickling. She has a firm uterus and tachycardia. What could be the cause? All right. I actually don't disagree with red. I'm looking at what you guys did here, and this would be considered early postpartum hemorrhage, depending on how much blood she's losing. And we talked about our 4 T's for early, right? Is tone, tissue, trauma, and thrombin. And this could be trauma. Okay. How do I know that it's a laceration? Like what signs, what clues in the question makes you think it could be a laceration?
The trickling, blood trickling from
Mm-hmm.
uterus.
Yeah,
Especially
Firm
because the
uterus.
uterus is
bright
firm.
red blood trickling.
Firm.
Yes, good. So we have bright red blood trickling and the uterus is firm. So that tells me it's not atony because uterus is firm. So where's the blood coming from? And it's this constant little trickle. That's probably laceration. Okay. What's a precipitous delivery?
Within 3
A
hours.
fast one, a quick delivery under 3 hours or under.
Yeah. So it's fast, under 3 hours. And so in addition to having the possibility of having lacerations, because that is common if we're delivering so fast, what other risks do you think to mom after having a precipitous delivery?
It could be hemorrhage,
Mm-hmm.
because it's fast, it's hard to control.
Yep. Do you think if she has this 3 hour delivery or less, her uterus has been contracting like crazy? Do you think it wants to do great contracting after the baby's out?
Oh,
It's
so you might
tired.
have complications for like a boggy
Yeah.
uterus.
So we could have a
So
boggy uterus or uterine atony. We could have lacerations. We could have hematomas. She's a huge bleeding risk. Okay. If she had a hematoma, so this one gave us a laceration. It said we had continuous blood trickling. What if she didn't have a laceration? What if she had a precipitous delivery and she had a hematoma? What signs might we see if she had a hematoma?
the purplish color of the vulva,
Uh-huh. What might prompt you to look for a hematoma?
Swelling, heat,
Well, what might we see with our patient that would make us think, I wonder if she has a hematoma? What do you think? I mean, you guys are right about what it would look like, but what would prompt you to even look for one?
changes in the
vital signs.
signs.
Oh, vital signs. Also, Ava, I want to come back to what you're saying too. Let's talk about vital signs first. What vital sign changes might you see that would prompt you to think maybe she's bleeding from somewhere?
Blood pressure and pulse.
Blood pressure and pulse. So usually pulse first. And what happens to the pulse?
It elevates, it
The
goes
pulse,
up.
the pulse goes up and the blood pressure drops.
It
Good.
goes up.
Okay, so vital sign changes might make me think maybe she's bleeding. So let's say we check on, she just had precipitous birth. We go to check on her and she's tachycardic and hypotensive. So honestly, the first thing I'm going to want to do is check her fundus, right? Because the number one thing is going to be uterine atony. So I'm going to check her fundus. And according to the story, her fundus was firm. So we massage the fundus. It's firm. She's tachycardic, firm fundus. Instead of seeing the bright red blood trickling that the question gives us, what if instead we saw something else? The pad was actually fine. The bleeding was fine, but she's got a firm fundus and tachycardia. What I could look at her vulva and see if I see hematoma, but sometimes it's kind of tucked up in the vagina too. So the other thing we could see with a hematoma might be her having pain. Like, wow, it really hurts down there. Okay. Maybe it's hard to pee. If that hematoma is getting larger, it could put pressure and make it hard for her even to go to the bathroom. So pain can be a big sign as well. So if they're having a lot of pain in their vaginal area, that could be a sign. So if we have a patient who's got tachycardia and a firm fundus and we don't see blood on her pad, we should explore hematoma.
Mhm.
If she has tachycardia and a firm fundus and bleeding, we should explore laceration. If she has tachycardia and a boggy fundus, we should go all in on the uterine atony. Okay, so what do we do for uterine atony besides massage the fundus?
Medication, the magnesium sulfate. I mean, hold on.
Not
For
this.
acne, will we help to promote contractions if we cannot firm it with the massaging?
Yep.
So we provide the oxytocin.
Yep. What other medicines make the uterus contract besides oxytocin?
The mythos, no, the misoprostol,
Mm-hmm.
misoprostol.
So that's misoprostol, and the other name for that is Cytotec. So we could give her oxytocin, we could give her Cytotec or misoprostol. There's two others we could give for acne, uterotonics. Not for this. We think about medicines that are going to make it squeeze. Uterotonics. We have 4 medicines that squeeze and 4 medicines that relax.
Oh, I know.
Ergo meat. I don't know how to say that name. Cabo Frost, something like that.
Mm-hmm. And carboprost is, Cytotec is one. Carboprost is also known as hemabate.
Cervidil.
What's that?
Cervidil.
Not Cervidil. Not Cervidil. Cervidil is a prostaglandin that we'll use to induce labor.
Okay, uterotonic. I'm sorry.
Let's look at. I think I have them all in one spot. Let me find it. Hmm. Well,
If we
I
already
thought
say the dino, we did say the dino cross on,
well,
right?
and that's not going to be for this.
Would it be the gems?
So when we think about our medicines that squeeze, we have Pitocin. Okay. There's an acronym for each one. There's an acronym for relaxing and acronym for squeezing. So Methergin is one. So if we think about squeezing, if our patient's bleeding, we probably need help. So here we go, uterotonics and tocolytics.
Does it want to start with an H?
Yep.
Hemabate.
Hemabate. Yep. Here, this is what I was looking for. So here we go. If we want to squeeze, we probably need help. So please come help me is our acronym we can remember. That's for Pitocin. Cytotec, which is misoprostol, is the other name, Hemabate, which is carboprost, and Methergin. These are our squeezers. These are our uterotonics. So if our patient has postpartum hemorrhage from uterine atony, these are the medicines to give. Okay. If our patient is in preterm labor, we use the, what's that? If our patient's in preterm labor, we use the acronym It's Not My Time because we don't want the baby to come yet. And these are the medicines that help the uterus relax. Indocin, nifedipine, magnesium sulfate, terbutaline. So these are the 4 that squeeze. These are the 4 that relax. Okay, so for my patient, my postpartum patient that's bleeding, these are our 4. Okay. What's the best response when the woman who tells the nurse she feels tired and sick all the time since I had my baby 3 months ago?
Oh, mine didn't change.
Yeah, good. Let's talk about this further. I'm concerned about how you're feeling. What do you think is happening with her?
Postpartum depression.
Yeah. Why do you think that?
She's just showing signs of constant tiredness, feeling sick all the time. Some of those signs and symptoms can be associated with postpartum depression. You just have a concern for her psychosocial. Does she have support? She's not getting enough rest. That could be an indicator of not being able to manage well.
Mm-hmm. Yeah. Okay. And so I'm concerned about how you're feeling. Let's talk about this further, is a good therapeutic response so that we can kind of try to gather more information. What other signs might she have if she has postpartum depression?
Might have poor visual presentation. She might not look well. She might
Yeah.
look flushed or fatigued or drained. She might have other concerns as far as possibly like safety concerns, environmental concerns.
Sure. Yeah. And oftentimes we can see these patients that may not be bonding well or detaching from their babies. Sometimes they can have thoughts of self-harm, even though, like, because even your patient that has depression, like not related to postpartum, can have thoughts of self-harm, right? The difference for that between that and psychosis is with psychosis, they're like impulsive and acting on these things. But with depression, it's more of just a feeling of worthlessness. You know, everybody would be better off without me. Um, with psychosis, though, and she's not exhibiting signs of psychosis currently, we'd be more concerned with psychosis because then they have symptoms that are a lot more severe.
Suicidal.
They can have suicidal ideations, homicidal ideations. They're impulsive enough to act on it. They also, with psychosis, they can also like be hearing things and seeing things. So they can have hallucinations and a lot of other stuff.
And infanticide.
Exactly. The client understands their insulin needs in the second half of pregnancy if they state they may require. So we talked about this at the beginning with diabetes, when we were discussing diabetes before we started the game. Okay, good. So if they, in the second half of pregnancy, their insulin needs go up. Do you remember why?
There's a baby. The baby needs insulin too.
The baby's making their own insulin, but that's not why mom's insulin needs are increasing.
She should also be increasing her caloric intake, so she may need increased insulin to also to support the weight gain promoted with the birth.
Okay, so she is increasing her caloric intake. That's true. The other thing that's really happening here is that her body becomes more and more insulin resistant as the pregnancy progresses. That's actually true for every pregnant woman. Every pregnant woman develops some level of insulin resistance because that's like a normal thing the body does. It's one of the hormones that the placenta releases to try to have extra glucose to grow a baby. But for your patient who's diabetic, that's not good because she was already insulin resistant oh my gosh, to begin with. And now her insulin resistance is getting worse and worse. And so, in order to keep her sugars in a normal range, her insulin needs might keep increasing as she becomes more and more resistant. Okay. And that's especially true for your patient who has diabetes before they get pregnant. Because as we talked about in the very beginning before we start playing the game, oftentimes women who develop gestational diabetes can be controlled with diet. It is sometimes possible that they need insulin as well, but their insulin resistance is not nearly as significant as a patient who had diabetes before they got pregnant. Okay, so insulin needs in the second half of pregnancy get higher and higher and higher, and then as soon as the baby's born, it quickly goes back down to what they were before they got pregnant. And sometimes their insulin needs will be even less still because, especially if they're breastfeeding, their insulin needs will be less after the baby's out. The nurse is caring for 4 3-day postpartum clients. Which client assessment requires the need for follow-up? Yep, good. So we talked about this. What do you think could be happening if she's 3 days postpartum and she has a foul-smelling odor in her lochia?
Infection.
What is that
Mm-hmm.
infection?
And which infection do you think it might be if it's causing foul-smelling odor in her lochia?
That sound choreo.
The infection is choreo, probably if she was still pregnant. But remember, choreo is an infection of the chorion and the amnion, which are part of the pregnancy. After
So we're in
delivery,
You said it's an
three.
endometriosis, so it's an endouterine infection.
endometritis.
Endometrius.
So the infection that originates in the uterus after delivery is typically at the placental site in the endometrium, so endometritis. So the common infection in labor is chorioamnionitis. Common infection postpartum is endometritis. They're both in the uterus. I apologize, guys. G2P1, blood pressure is 172/114. Proteinuria, headache, difficulty focusing. Good. So what is it describing?
Eclampsia. Describing
It's
worsening.
Seizure
describing
precaution. So they're on their way to possibly to a seizure. So you want to try to medicate and provide comfort in case they do seize.
Okay, good. So she's got proteinuria, headache, difficulty focusing, blood pressure is really high. So we definitely she's preeclamptic, and so when they're preeclamptic, we're trying to prevent eclampsia, which is the seizure. What might we do to help keep her from having a seizure?
Mag.
Magnesium sulfate.
Mag.
Magnesium sulfate. Yep. What are some things that we're monitoring for? If we put her on magnesium sulfate, what do we need to watch for?
Toxicity. So we're looking for
Everything would decrease. She will have like decreased respiration.
Respiration,
It's like everything is slowing down.
Mhm. Yep. So decreased respirations is a big one. Muscle weakness, slurred speech.
level of
What
consciousness, yes.
Decrease
Yeah,
out urine
changes.
output.
Decrease urine output. How much urine output do we want to see?
30 mLs per hour.
At least
Or
30
more.
mLs per hour. Yeah. Also, we're worried if we have so I think it was Alicia that just said everything would decrease. So we would be worried if we have absent deep tendon reflexes.
Right.
Okay. Yeah. And so if we have signs of toxicity, what would be our antidote for magnesium sulfate?
Calcium gluconate.
Calcium gluconate. Yep. And all of this is to try to prevent eclampsia so she doesn't have a seizure. A nurse is administering prescribed medications prior to a cesarean delivery. What should the nurse administer? Okay. Antibiotics and antacids, okay, is the choice here. Since we're opening the uterus, we need an antibiotic to try to minimize the risk of infection. Antacids, because if she's laying on her back and she vomits, which sometimes happens, we don't want her to aspirate really acidic stomach contents. The reason that red isn't the better choice is we don't need to sedate her. Okay, we could do pain management, but usually they can do that with either a spinal or an epidural. So we don't need to give her painkillers necessarily, and we definitely don't need to sedate her. But we do need to give her antibiotics and minimize her stomach acid. A 37-week gestation is admitted with vaginal bleeding following the use of cocaine 1 hour ago. What is the probable cause of her vaginal bleeding? Okay, let's talk about this. So she's 37 weeks. So she wouldn't be having a spontaneous abortion because spontaneous abortions happen when?
They happen early in pregnancy. It just I was trying to touch
Before 20 weeks.
the one above it, and it is spontaneous.
Oh, okay. So spontaneous is going to be before 20 weeks. Ectopic pregnancies are pregnancies that implant in somewhere other than the uterus, like the fallopian tube. So that brings us down to placenta previa or abruptio placentae, which is a placental abruption. Placenta previa is going to have to do with where the placenta attached in the bottom part of the uterus overlapping the cervix. Abruptio placentae is when the placenta starts to separate from the uterine wall before the baby's born. And this is something that definitely can happen with cocaine use. Cocaine tends to have no problem just blasting that placenta right off the wall. Do you think that this is dangerous?
Yes.
Yeah. If this patient has abruptio placentae, is she delivering today?
Yes, you should definitely prepare for delivery.
Emergency
Okay.
delivery.
And how are we going to plan on delivery for her?
C-section.
C-section.
Very.
Good. What might we see besides the bleeding if she has a placental abruption?
The fetal heart rate is going to be impacted.
Possibly. And also, what kind of decelerations might we see with the fetal heart tracing?
Variable.
Right.
No, there'll be
It's not gonna
late
be-
decelerations. There'll be late decelerations because of the trauma.
There'll be late decelerations because that the amount of the placenta that has separated from the uterine wall, we're now not getting that blood flow into the placenta in that spot. So it's going to create a placental insufficiency.
Mhm.
Okay. So late decelerations, bleeding, what else?
Pain.
Pain. Placental abruption is painful, right? So we could see pain, we could see like board-like rigid belly, in addition to the bleeding, in addition to the late decelerations. Nurse in labor and delivery is providing care for a client who's in preterm labor at 32 weeks. Which of the following medications should the nurse anticipate the provider will prescribe to hasten fetal lung maturity? Good. What about these other medicines? What does calcium gluconate do?
The antidote for magnesium toxicity.
Good. What about nifedipine?
Oral hypertension medication.
Yep. So we use nifedipine for our patient that's preeclamptic. It also is a uterotonic. No, sorry. It also is a tocolytic. Okay. What I mean is that it can relax the uterus. So if the question said which medication should the nurse anticipate to decrease contractions for a 32-week gestation, nifedipine might be a choice. Okay, because it does relax the uterus. Indomethacin is also a tocolytic. That one
For
we
uterine.
usually, go ahead.
I'm saying, is it also used for like anti-inflammation?
It's an NSAID.
It's an NSAID. And so indocin is an NSAID and it has tocolytic properties, but we don't usually use it at 32 weeks and beyond because it can cause the ductus arteriosus for the baby to close. And so, but we do use it for preterm labor prior to 32 weeks. But if the question said, what might we anticipate using to decrease her contractions, nifedipine would be a good choice for her. Because it says, what are we going to use to hasten fetal and lung maturity, betamethasone is the best choice because that's what we're going to give to mom to help the baby. It helps increase the surfactant production in the baby's lungs in case they're born early. A pregnant client presents to the clinic with complaints of a severe headache. What should we do first? Check her blood pressure first. Okay. Headache can be a sign of preeclampsia. Headache can be a sign that she's having a bad day. Okay. Headache by itself isn't necessarily concerning, but it is if she's developing preeclampsia, and a good way to know that is to take her blood pressure. If I take her blood pressure and it's less than 140/90, then maybe Tylenol is a good choice for her. Tylenol can be a good choice either way, but it's not a priority, right? But if I take her blood pressure and it's elevated, then we need to do some other things. So if she comes in with a headache and her blood pressure is 152/94, then what should we do?
Maybe give her the nifedipine.
We could give her nifedipine. But what
Hydrazoline.
else? So we could give her medicine for her blood pressure.
But
What other? Truly, unless her blood pressure, though, is greater than 160 over 110, they won't necessarily medicate it right now. They probably will do lab work and look at, like, do their assessments. She's in the clinic, so I don't think they're going to give her hydralazine in the clinic. So, but they could send lab work for sure. Which labs are we looking at?
Liver enzymes.
Mhm. Liver enzymes.
Creatinine.
Mm-hmm. There's a big one that we check here. It's in the P.
Protein in the urine.
Protein in the urine. Yep, so we'll check for protein in the urine, and then we can do blood work for AST and ALT, which is liver enzymes. We can also check creatinine, and we can also check for thrombocytopenia. So they would do labs. And then they probably would also have her go to the hospital. And then it would depend, there'd be other factors that would depend for sure what happens next. But let's say she's term and she's got blood pressures are 150s over 90s and she's got a headache. They'll probably induce her. And then depending on the severity of her symptoms, they might also start magnesium sulfate. To try to keep her from developing eclampsia and having a seizure. The nurse is caring for a client receiving terbutaline to prevent preterm labor. Which maternal assessment finding would be relevant to consider prior to administration of terbutaline? Okay. Terbutaline causes tachycardia. So if she's already tachycardic, we probably want to notify the provider before we administer the medication. So we started the game late because we were talking about math, we were talking about diabetes, and we still have a lot of questions. Do you guys want to keep going?
Yes. Yes, please.
Nurse observes the client's amniotic fluid and decides that it appears to contain meconium because hold on a second. Oh yeah. I was just my brain was only looking at the white little specks and I was like, why is that meconium? All right, so why do we think that this is meconium?
The green speck, the green and little white specks.
Well, and the little white specks in and of itself could be vernix, which was why when I first didn't read it clearly, which is what we tell you guys when you're taking your test to make sure you read it clearly, read the whole thing. I thought, well, that could be vernix. But the fact that it's also green, meconium. What kind of risks are associated for the baby if there's meconium stained fluid?
Respiratory
pneumonia.
Respiratory distress.
Expiration.
Because the baby breathes in that fluid, right? And if we put meconium in the alveoli, that's going to interfere with our gas exchange. Okay, so it can cause respiratory distress and even pneumonia for the baby. The nurse should recognize the emergence of the fetal head followed by retraction against the perineum as what sign? This is a turtle sign. So we talked about this before when we were talking about shoulder dystocia. If the head comes out and then retracts back, they call that the turtle sign, like a turtle ducking his head in his shell. That is a good sign that we should lower the head, do some McRoberts, and maybe call for help. The nurse is assessing a client in the immediate postpartum period. Which of the following signs or symptoms would indicate the client is experiencing uterine atony? Good. So we've talked about atony a lot today. So I think you guys know that one pretty well. A nurse is admitting a client at 42 weeks for an induction of labor. What is a predictor that the induction will be successful? Okay, so if you guys remember, so 3 of you answered Bishop's score. Do you guys remember how we do Bishop's score?
By checking readiness for labor, like cervix, effacement, if they have a score 8 or better.
Dilation.
Good. Yep. Good. So we look at the dilation, the effacement, the consistency, position, and those things. And if the score is 8 or better, that's a good indicator that the induction will be successful. If the score is less, then what should we do to help get the cervix ready for labor?
You'll have to provide oxytocin or non-pharmacological factors like exercise, like walking.
We could.
Uterotonics.
Uterotonics are going to help the uterus squeeze. We could do that, but if our Bishop score is low, we should first think about how to ripen the cervix or make the cervix more ready for labor. And so, what's that?
Yeah, yes, that's what I ripen the cervix.
Okay, so this would be a time for dinoprostol. This would be a time for Cervidil. This would be a time we could use Cytotec in a tiny dose for this because Cytotec in a tiny, or misoprostol in a tiny dose, acts as a prostaglandin. We use it in a large dose for uterotonic. In tiny dose, it's going to help soften and ripen the cervix. So we can do some of the non-pharmacologic things and have her walking. Semen is a prostaglandin. Sometimes they'll have them, like if we're not in the hospital trying to induce labor, if she's just trying to get ready for labor, they might tell her to have sex at home. Not at the hospital. At the hospital, we're going to be doing things, if the Bishop's score's low, we're going to be doing prostaglandins. Or we could do, if the cervix is open a little bit, we could do a cervical ripening balloon. So you could do mechanical dilators, you could do prostaglandins, things like that to ripen the cervix. If the Bishop score is low, the Bishop score is high, we could just give her oxytocin and give her some contractions, and she probably would very successfully labor from there.
Aren't the uterotonics ripening for ripening?
So the uterotonics, the main uterotonics are the ones we talked about for hemorrhage, right? So Pitocin, we'll use that in small doses for labor. I have seen them use oxytocin or Pitocin in a low dose for a while to try to help ripen the cervix. But typically the prostaglandins help better for ripening. And then the Cytotec in a low dose, or misoprostol in a low dose, can help for ripening. The other ones, the Hemabate and the Methergin, we don't use that for ripening. That's only going to be to make the uterus squeeze very well after the birth of the baby, if we have uterine atony. A client is receiving oxytocin to augment her labor. Which assessment findings should cause the nurse to immediately discontinue the oxytocin infusion? Okay. So just because for yellow, just because she's not having accelerations in and of itself doesn't mean we need to turn off oxytocin. Accelerations are very reassuring, but an absence of accelerations isn't necessarily concerning. Does that make sense? Early decelerations are caused by what? What causes early decelerations?
The O for chop.
Early deceleration should be the H in CHOP.
The H. Oh yeah, yeah. It's head positioning, head compressions.
Good. Head compression. And then Rachel also has that in the chat. So head compression would be early decelerations. Is that a concerning thing?
No, it's okay.
It's okay. Late decelerations, though, that's what we're concerned about. Late decelerations are going to be the P in CHOP, right? So placental insufficiency. And so when we think about why a placenta is insufficient, in this case, it could be that we're not getting enough blood flow to the placenta in between contractions. So we need to discontinue the oxytocin infusion if we're having late decelerations because that we're not getting good oxygenated blood to the baby. And it could be because the contractions are too close together, too strong. Okay, so late decelerations we're concerned about. So discontinuing the oxytocin is one of the things we should do if we're having late decelerations. So if I'm giving oxytocin and I see late decelerations, I should turn the oxytocin off. An assessment for what complication has the highest priority for a client with severe postpartum hemorrhage. Good. Yeah, that's really good. You guys all got this. So if she is having a postpartum hemorrhage, we need to be watching for DIC. What might we see with DIC?
Clotting factors like PTT levels.
What might we see in our patient on assessment?
Blood pressure and pulse
Okay, we
rate.
can see, yep, we can see tachycardia and hypotension as our vital sign changes. The thing with DIC, guys, is that this is called a consumptive coagulopathy. Basically, all of the clotting factors are being used in places that aren't helpful. And so everything is bleeding. So what we might see is like blood in the urine. We could see oozing at like any injection sites. We could see petechiae on her skin where the blood pressure cuff is squeezing. Anything that could bleed is bleeding with DIC. Which medication should the nurse expect to administer to a client who's experiencing preterm labor? Okay. Preterm labor, we want tocolytics, right? It's not my it's not my time. Indocin, nifedipine,
Magnesium.
magnesium, terbutaline. Okay. All the other medicines that are listed here are uterotonics. So please come help me. Pitocin or oxytocin, Cytotec, which is misoprostol, Hemabate, and Methergin are the squeezers. We don't want to give a patient in preterm labor a squeezer. We want to give her a relaxer. Okay, it's not my time. So nifedipine for her. The nurse knows to frequently assess the following to identify magnesium toxicity. Okay, we talked about this already on a different question, right? If we have toxicity, we would be concerned about absent deep tendon reflexes. We'd be concerned about respiratory rate. I think maybe Alicia was the one that said everything slows down. Might have been Brandy. So we'd be concerned about decreased respiratory rate. We'd be concerned about absent deep tendon reflexes. We'd be concerned about changes in level of consciousness, and we'd be concerned about urine output less than how much?
30 ml
30.
per hour.
Mm-hmm. A new mother has saturated 2 pads in 30 minutes and has a boggy uterus. What action should the nurse implement first? Okay, bundle massage. First thing with a boggy uterus is to massage a fundus. Now, having the client empty her bladder, the bladder is a good thing to consider because that could be contributing to the contractility of the uterus. And even like if I assess a patient, if I'm just checking her uterus and I find that it is, or actually maybe I'll just ask you, if her bladder's full, what might I find on her assessment?
Distension.
To find bladder distension, what kind of things might I find with her uterus if her bladder's full?
It could be
Uterine
boggy and
displacement.
painful.
Could be boggy. And then Alicia, what else are you saying?
I said it could displace the uterus. It'll be like shifted.
Yeah, good. So if the bladder fills, it can push up on the uterus and shift it. Okay, so then it can be displaced from the midline. So it might be right or left and higher than it was before. So usually we expect to find it at the belly button, right? But if it's now like above the belly button and displaced to the side, then that could definitely be a sign of a full bladder. A full bladder is definitely going to affect the way the uterus squeezes. So for this patient, massaging the fundus is the good first thing to do because the fundus is boggy and she's bleeding a lot. But the other things to consider are going to be managing her bladder. And for this one who's bleeding, has 2 pads in 30 minutes and bog uterus, I might put in a catheter for her. I might not get her up to the bathroom because she's bleeding a lot. But we need to manage the bladder somehow. Empty your bladder, do a Foley, have her void, something. And then we also then can give our uterotonics. Okay, so uterotonics, make it squeeze. Please come help me. Pitocin, Cytotec, Hemabate, Methergin. Right? The uterine fundus right after delivery of placenta is palpable at what? I actually just said this. Where do we expect to find it right after the baby's born? Good. So usually at the umbilicus or just below. All right. I don't anticipate finding it between the umbilicus and the pubic symphysis for some days. Because remember, it goes down about a centimeter a day. It's typically right at or just above or just below. So the belly button is a good landmark. What is the primary goal for treating gestational diabetes? Oh, Ava, this question's for you.
Yeah.
Yeah, we just talked about this. That was what she came in wondering more about was diabetes. Okay, primary goal for gestational diabetes is to decrease the macrosomia.
Yes.
Okay, now I want to talk about this because look at the blue answer and the red answer. Those are both things that can happen with diabetes, right? But not with gestational diabetes. Okay, because congenital malformations and spontaneous abortion happen before a patient that has gestational diabetes is diabetic. So these are things that could happen for a patient that has poor glycemic control and she has pre-gestational diabetes. Okay, so it's an important thing to be able to differentiate between the two in that for all diabetics, it's important that we have good glycemic control. It's important that we are teaching, them to all the things, right? To check their glucoses regularly, to eat a good diet, to exercise after meals, fetal monitoring. I'm trying to think if there's anything else. It's going to be really important to teach all of them about good glucose control. But your patient that has gestational diabetes doesn't have the risks of early pregnancy that your patient that was diabetic before she got pregnant has because she wasn't diabetic yet. So that's why for this question, blue and red weren't choices because she's a gestational diabetic. That makes sense? Rh negative women with threatened abortion should receive RhoGAM. True or false? That's just going to be true. Good. So what's a threatened abortion?
It is signs of like it's a closed cervix with possible bleeding, no pain. So the probability is there, but you still have time to save it.
And our baby still has a heartbeat. Yep. Okay. So we've got some bleeding happening. Sometimes they can be a little crampy, but the cervix is closed, like Nikayla says, and we still have a heartbeat for our baby. That's a threatened abortion. With a threatened abortion, we want to try to maintain the pregnancy. And so we might do a little bit of bed rest. Okay, so we don't usually encourage bed rest in women anymore because the increased risk of blood clots and things like that is way worse. But for somebody who's really close to that age of viability, we might do a little bit of bed rest and limited activities and pelvic rest and those things. But she should also get RhoGAM if her RH is negative because we don't know if the baby's RH is positive. Okay. And then we're going to just try to keep her pregnant. A fetal heart rate is checked following rupture of bag of waters in order to what? Okay, only one of you answered. You answered correctly. So remember we talked about this earlier that when the bag of water breaks, that's a primary time for a cord prolapse. But even if the cord didn't prolapse, we've changed the way that the cord, because the cord's not really floating in the fluid now, we've changed the way that the cord is being cushioned. And so we could see signs of cord compression when the water breaks, even if it's not a cord prolapse. So we need to look at the fetal heart rate and see if we see variable decelerations. Two hours post-delivery, the fundus is 3 centimeters above the umbilicus and to the right. What can bladder distension cause postpartum? Okay. So this is one that we talked about before, that if the uterus is deviated from the midline and it's above the umbilicus, then that could be a sign the bladder's full. And if the bladder's full, it's going to decrease the contractility of the uterus. And so excessive uterine bleeding is the big concern here. The nurse is educating a diabetic client to do kick counts. What's the benefit of teaching to do kick counts? Good. So fetal movement is a great indicator that our baby's doing well. Babies that are hypoxic are not moving around. Okay, it's normal for babies to have sleep cycles and not to move all the time, which is why we have them count for an hour or two. But ultimately, if we're not getting good fetal movement, then they should notify the provider. Chronic hypertension is defined as hypertension prior to when? "20 weeks." Okay, 20 weeks is a good cutoff for a lot of things. All right, and so before 20 weeks is chronic hypertension. Diabetes that develops after 20 weeks is gestational. Hypertension that develops after 20 weeks is gestational. We use 20 weeks for a cutoff for a lot of stuff. A PPROM client is receiving magnesium sulfate for neuroprotection. The nurse should monitor for which adverse effect? Good. So this patient is not on magnesium sulfate because they're preeclamptic. They're on magnesium sulfate because the water broke in their preterm. So remember, guys, that magnesium sulfate has a tocolytic effect. It can slow contractions down. It also can provide neuroprotection for a preterm baby. It helps protect the vessels in their brains. So we use it to give us time to get betamethasone on board if she's preterm by slowing contractions down, and also to give the baby protection for their brain. But we have to monitor them for all those same signs of toxicity that we talked about with our preeclamptic patient, because magnesium sulfate doesn't differentiate whether she's taking it for preeclampsia or she's taking it for preterm labor. It's still going to have the same effects on the mom's body. Okay, so watching for signs of respiratory depression. And PPROM, guys, is premature, so she's before her due date. Pre-labor, she hasn't started in labor yet, rupture of a membrane. So this patient's preterm and her water broke, and that's why she's getting that medication. Yay! Of those that are still playing, because I know this has been really long and we've had some drop-offs along the way. But I think we also had a lot of really good discussions about a lot of things. Anything you guys have questions about?
No, thank you so much, Professor McBride.
You're welcome. I'm glad we got to have so much time to just kind of just play through the whole game today. And we did a lot of math at the beginning. So hopefully you guys are well prepared.
Yes, ma'am. Thank you.
Oh, Ava, will you do me a favor real quick before you hop out? Will you change your name so that on the Zoom log it shows who you are so that I can let your professor know you were here?
I don't know if I
Are
can.
you gonna send the recording?
Yeah, the recording will be sent to all the other instructors and it'll also be posted for my patients. Oh my gosh, for my students, it'll be posted in your announcements.